It truly is inspirational every day to step on the campus and to realize exactly how many lives are enhanced and touched by the work that is done there every day. And as Mary Catherine said, this whole program came from a partnership because of a gift made from Mrs. Clifford Graham. And it's fitting because the gift that she left to our Health Science Center supports diabetes research. And so it is with great pleasure and honor that I would like to introduce to you one of our outstanding faculty members, Dr. Ralph DeFronzo. Dr. DeFronzo is Professor of Medicine and Chief of the Diabetes Division at the University of Texas Health Science Center and Audiel Murphy Memorial VA Hospital in San Antonio. Dr. DeFronzo is a graduate of Yale University and Harvard Medical School and did his training in internal medicine at the Johns Hopkins Hospital. He completed fellowships in endocrinology at the National Institutes of Health and Baltimore City Hospitals, and in nephrology at the Hospital of the University of Pennsylvania. Subsequently, he joined the faculty at Yale University School of Medicine as an assistant and associate professor. From 1988 to present, Dr. DeFronzo has been Professor of Medicine and Chief of the Diabetes Division at the University of Texas Health Science Center, San Antonio. He also serves as the Deputy Director of the Texas Diabetes Institute. Dr. DeFronzo has received many awards for his work, including the highest scientific achievement awards given by the American and European Diabetes Associations. With more than 550 articles published in peer-reviewed medical journals, Dr. DeFronzo is a distinguished clinician, teacher, and investigator who's been invited to speak at major national and international conferences on diabetes mellitus. Please join me in welcoming Dr. Ralph DeFronzo.
It's a pleasure to be here. Actually, I've never been to Cuero before, but as an old jock and football player, I know that the rushing record in high school football is actually owned by a young man who played here in Cuero, although I think it was just broken this year. So we're a small group. I plan to do this in a very informal way. The American Diabetes Association was very nervous about what I was going to say, so they sent their president to keep an eye on me here, John Griffin, and also a lawyer to make sure that I didn't say anything that was illegal. You know, nowadays, every time you get up to give a talk, the first slide has to be all of the companies that you work with. So that you have to disclose your past. And now it's gotten so bad that you cannot accept any gifts from any pharmaceutical company or anybody who works in the medical profession. And so as they unveiled all of these rules and I was sitting there, I was talking to this fellow next to me. I said, well, what is a gift? And this lawyer who was doing the presentation overheard this, and he said, a gift is anything that is 1 penny in value or more. So obviously I don't have any allegiance to any pharmaceutical companies anymore. So we're a small group, and I'm going to make some general comments, but you should all feel free to interrupt at any time you want. So let's start off by how many people here have diabetes? So a lot of you. And for those of you who don't have diabetes, how many of you know someone who has diabetes? So you can see this is a really common problem, and virtually everybody I know knows someone who has diabetes and is involved in their care in some way or another. And lay people tend to have a lot of myths about what diabetes is and what it is not. So in a very, very simple term, our body regulates all of the energy needs of the cells in the body by getting glucose into the cells, and you burn the glucose, you burn the sugar, and from that you generate energy. We have very sophisticated biochemical terms for this, the energy is stored in the form of ATP, but unless you're able to burn that glucose normally, you don't generate ATP molecules. So for the ladies, when you get up in the morning and you comb your hair, that's because you had enough glucose that got into the cells that allow you to have your muscles contract. So John and I, as we get older, we have less hair to comb, so we don't need as much sugar in our cells. And what regulates how much sugar gets into the cells is how much insulin that's made by our pancreatic beta cells and how our body responds to that insulin. So when we talk about diabetes and we break it down into the most general terms, there are two types of diabetes. One is very simple, it's type 1. The other is type 2. You know, in Italian it's uno and due. It's very simple. Now, type 1 diabetes is, of course, less common than type 2 diabetes. There are about 1.5 million people in the United States with type 1 diabetes. There are about 27 or 28 million people with type 2 diabetes. And these are very, very different diseases. We treat them very differently, but the kinds of complications that people get are very, very similar. So what is type 1 diabetes? This is the type of diabetes that's more common in children, and individuals with type 1 diabetes lack insulin. So why do they lack insulin? Well, this is, of course, one of the great mysteries that we're all interested in trying to elucidate. But basically, for reasons that are not totally clear, the body decides that the beta cells which produce insulin don't belong in your body. They're somehow or other recognized as being foreign. So, of course, if you develop kidney failure and you were to give me your kidney and I put it in my body would recognize your kidney doesn't belong there. So it would try to reject the kidney. There's an immune response that occurs that causes rejection of the kidney. But people with type 1 diabetes, they're born with their own pancreas, their own beta cells that produce insulin, and for some reason or other, the body's immune system decides that that pancreas doesn't belong there. And it rejects the pancreas and it kills off the beta cells. And we call this immune destruction. Now, of course, there's an enormous amount of research, work that's supported both the American Diabetes Association, the Juvenile Diabetes Foundation, and National Institutes of Health, to try to define why is it that our immune system decides that the pancreas doesn't belong there. Over the years, I think we've learned a lot about the genetic background of people who are predisposed to develop type 1 diabetes. They have certain genes that we can identify. We know that at a certain point in time, even though they've had these genes all of their life, something tells these genes to work in a very negative way to destroy the beta cells that are there. Now, what is it that incites this immune response? Well, the fact is, we don't really know. One of the things that we know for sure is that people who have rubella, which is a virus, this can incite the immune response. But this is like 0.00% of all of the cases of type 1 diabetes. So even though we've learned a lot, we know exactly what cells are involved, how the immune response goes, we don't really still understand what is the inciting agent. But what happens is that over a relatively short period of time, when the body decides your pancreas doesn't belong there, you eventually kill off the beta cells, and at some point in time, you end up with virtually no beta cells. Those are the cells that produce insulin. Without insulin, you can't get glucose into the cells in your body. And of course, these people require insulin for the rest of their lives. And I'm going to come back and talk a little bit more about the treatment of type 1 diabetes. And as I said, there are about 1.5 million type 1 diabetic individuals. And what we've noted, and again for reasons that are unexplained, the incidence of type 1 diabetes is actually increasing in the United States. And no one really understands why the incidence is increasing, because the gene pool has really remained unchanged. The big problem, at least in numbers, is type 2 diabetes. So type 2 diabetes is what usually comes on later in life. We used to call it the adult onset diabetes, and type 1 used to be called juvenile onset. Well, it turns out that the youngest kid with type 2 diabetes is actually several months of age, and the oldest person with type 1 diabetes is diagnosed in their 90s. So this juvenile onset and this adult onset has been thrown away for type 1 and type 2. And type 2 is a very, very different disease. So type 2 diabetes is two actually diseases rolled into one. One problem is that the tissues in your body don't respond to insulin normally. We call that insulin resistance. And what happens is that your beta cells can recognize there's something gone wrong. So your beta cells will secrete enough insulin initially to overcome this insulin resistance. But constantly, as your beta cells have to work to produce all of this insulin, they start to wear out. And when your beta cells wear out, then of course you're going to need some help. And we'll talk a little bit about some of the drugs that are available. And many people, the drugs that we have work for a time, but over many years and decades, even the drugs stop working, and many of these people end up having to go on insulin, and about 1 in 3 people with type 2 diabetes end up having to go on to insulin. And diabetic patients get two types of problems. One type of problem is related to the small blood vessels in the body. So the blood vessels in the eyes, which are the small blood vessels, can be damaged by high glucose. And this can lead to changes in the retina part of the eye that leads to blindness. And of course, diabetes is the leading cause of blindness now in the United States and throughout the world. When the small blood vessels in the kidney are affected, you damage the kidney, and eventually many of these people end up having to go on to dialysis. We refer to these as the microvascular, the small vessel diseases. All of these complications, the eye and the kidney complications and the neuropathy, you'll oftentimes hear diabetics complain of pain. They go to sleep at night and the sheet just laying on their feet is so painful that they cannot sleep. And in fact, many of them, people cannot sleep with a sheet on their bed. They lose their balance, they can't feel sensation, they can step on a nail and they don't even know that they stepped on a nail. All of those complications are related to two factors: how high your blood sugar level is and how long your blood sugar level has been elevated. So obviously it's very important that you keep your blood sugar within a normal or near normal range, and we'll talk about what is that range and how you go about doing it. Now the second type of complications that people with diabetes get, it doesn't make any difference whether it's type 1 diabetes or type 2 diabetes, involves the large blood vessels in the body. So the blood vessels in your heart, diabetics very commonly have heart attacks. And the blood vessels that go to your brain, very commonly diabetics have strokes. So the incidence of heart attack and stroke is increased 3 to 4-fold in diabetics. In part, that's related to how high your blood sugar level is, but the large vessel or macrovascular complications much more complicated. So it's not only how high your blood glucose is, it's what your blood lipid profile looks like. So how many people know what LDL cholesterol is? So hopefully everybody knows this is the bad cholesterol. You need to keep it within a normal range. And then there's a good cholesterol called the HDL cholesterol, and the higher that is, the better off you are. So there's a major impact on the large vessels of your blood lipid level. We also know that your blood pressure is very important in determining whether or not you're going to damage the large vessels in the body. So taking care of the diabetic is not simply controlling the blood sugar. Of course, that is critically important, but you also have to take care of these other risk factors. And we know that the incidence of diabetes has been increasing markedly in the last 20 years. And the incidence of diabetes, this increase, is almost entirely accounted for by one factor. What is that one factor? Obesity. Okay? So in the old days, rarely would you see people who have a body mass index about 30. That would be someone about this big. You walk downtown San Antonio and they're about this big now. They have body mass indexes that are 35 to 40. So a normal body mass index is less than 25. A little bit obese is between 25 to 27 and a half. Frank obesity is above 27 and a half. And unfortunately, some 80% of the diabetics have a BMI now that's 30 or above. Now, this incidence of diabetes is not because we've got a whole new set of abnormal genes that are causing diabetes. Unless you want to define the gene as what I say, the hand-to-mouth genetic abnormality. So people put too much food in their hands too many times and they move their hand to the mouth. That's a very, very bad gene. Now, when you gain weight and you become obese, you deposit fat in all the tissues in the body. So when you deposit fat, of course, in your pancreas, that kills your beta cells. Those are the cells that are making insulin. When you deposit fat in the muscle and the liver, that makes your tissues very, very resistant to insulin. When you deposit fat in your arteries, in the arteries that go to your head, you have a stroke. You deposit them in the arteries that go to your heart, you have a heart attack. So the most important factor that's changed our entire society in terms of diabetes is the obesity epidemic. And if we truly could get people to lose weight, if I took all of my diabetic patients and I could get them to get down to normal weight, I probably could get rid of 70 or 80% of the medicines that I use to treat these people with. But the fact is, I'm not very good at getting my people to lose weight, and I have to say my other colleagues, be they endocrinologists or primary care docs, really don't do any better than I do. Now, the other problem that's occurred is that our society's become more and more sedentary. And as we become more and more sedentary, physical inactivity makes our tissues very resistant to insulin. So you can now imagine, here's a person, he wasn't very smart in life, he picked his parents very poorly. So he has now all the genes for diabetes. And his or her beta cells trying to crank out all this insulin to overcome this insulin resistance that they've got from their parents. And now, what is the worst thing you can do? Gain weight. That makes you more insulin resistant. And as you gain weight, you start to feel sorry for yourself and you put yourself in the chair and you watch the TV and you don't go to the gym, and now you become physically inactive and now you become even more insulin resistant. Well, your beta cells can't crank out all of that insulin to overcome all of this insulin resistance. Part's genetic, but in large part, it's acquired. And so with time, because your beta cells have to work so hard, they wear out. And it's really the epidemic of obesity which is driving the epidemic of diabetes. It's not because we've had a whole bunch of new genetic mutations. And the unfortunate part of this, if you go back, when I was a kid in the 1950s growing up, you didn't see any overweight kids. Those were the unusual kids. Now you go to school and you see like 80% of the kids in the school system at a very young age are very overweight. Now, how are we going to solve this problem? I don't have a good answer for this because intervention programs that rely on behavioral modification to get people to lose weight and exercise have generally failed. So about 10 or 15% of people, these are now, if you put together the best programs in the country, 10 or 15% of people who enter into these programs of dietary intervention and exercise lose weight and keep it off at the end of a year. So for those people, of course, this is fantastic, because that means it's much less likely their diabetes is going to progress and that they'll need medicines. So that still leaves us with a large number of people. Now, it's taken us 50 years to get into this mess. Now, I personally don't like government intervention in anything, okay? But I believe in order to reverse the mess that we're in, we're going to have to go back, and this can only be done at a national level, or at least the state level. We're going to have to change what we do with young kids. Starting in kindergarten, first grade, of course there needs to be healthy food in the school system. If you go into the school systems, you see some of the food that they serve is kind of shocking. So that's number one. There needs to be a lot more education. We need to put physical activity back into school. So when I was a kid, we had 1 hour physical education, and then you didn't leave the school. You were there at exercise, and you would play dodgeball. If you were a guy, there was nothing that was more fun than trying to hit your girlfriend with a ball, as she said, in the middle. So there was a lot of activity that went on. Nowadays, there's very, very little physical activity, and we need to put activity back into kids' lives. And it's very difficult to start to reprogram people when they're 40 or 50 years of age. So I think we need to start at a very, very early level. And that means it's probably going to have to be designated at a much higher level rather than myself as a physician on a one-to-one basis trying to change the world, which I cannot do. So I think there's going to have to be some city, government, state intervention where we change people at a very young age. That even if we do that, remember the kids go home and they live with the parents. That means the parents need to understand what needs to be changed, and oftentimes the moms are very sensitive, but then the father says, God, you served that junk food, I can't eat that tonight. And so of course he complains, so the mom goes back to the old way of cooking, and then that exposes the kid to this very unhealthy environment. So this is a very, very complicated problem. Now, if you look at diabetes complications, one simple way for me to drive home the impact of how devastating this disease is to tell you that every day 4,000 people die from diabetes. Every day. That's an incredible statistic. 125 people every day end up on dialysis. 55 people every day end up going blind. Those are staggering numbers. Now, there's of course an enormous medical cost that's associated with this in terms of dollars, but above and beyond that, the quality of life for people who develop these complications cannot be accounted for in terms of dollars and cents. And I think oftentimes we lose track of this. Everybody wants to know about cost effectiveness. And of course, if you have a finite number of dollars that have to be doled out in society in general, then cost effectiveness is very important. But sometimes I think we get too carried away with cost effectiveness, and we don't do necessarily what's the best thing for our patients. And in the United States, I think that with appropriate sort of relegation of authority and where the money goes, that we can in fact do a whole lot better in terms of treating our diabetic patients. So, how are we going to treat people who develop type 1 diabetes? These people, of course, all have to be on insulin. And where does the future hold in terms of therapy and a cure? So people, hear all the time, within 10 years we'll have to find what the genetic problem is. We'll be able to go in genetic engineering and we'll change it all around and we'll have a cure. Well, this is actually a wonderful thing to say and think, but the fact is, this isn't going to happen probably in our generation, okay? Or it's going to take a lot longer. Science goes in little mini steps. it may be that someone working in a field is totally unrelated to diabetes makes the key observation that will give us an idea of how to attack the problem. For now, there have been many, I would say, really quite creative and innovative attempts to block the immune destruction of the beta cells, but they have in general all failed, or the medicines that have worked on a part-time basis are so toxic that you can't use them, particularly in young children. So for people with type 1 diabetes, insulin is always going to be the mainstay of therapy. But we've made enormous advances. Now, how many people here do use insulin? So there are a number of you who use insulin. You know, in the old days, it was hit or miss, because you really didn't know what your blood sugar level was. We used to measure the glucose in the urine. Well, we've gotten a lot more sophisticated now. Every person who has type 2 diabetes should have a glucose meter. And in the old days, we used to fight what is the best meter. Now there are, you know, a dozen of them that are all really quite good. And all people with type 1 diabetes, and this is true for type 2, should be checking their glucose. People with type 1 diabetes 3 or 4 times a day, and that allows you to adjust the insulin that you're taking based on what your blood sugar level is, and also based upon how much you're going to eat, particularly how much carbohydrate. So how many people do carbohydrate counting? Okay, so for people who are taking insulin in general, for every 10 to 12 grams of carbohydrates, 1 unit of insulin. It varies from, depends on how sensitive you are to the insulin, how resistant you are to the insulin. So we have a lot better ways of monitoring the blood sugar level. And we now actually have devices that you can implant a glucose sensor under the skin, and it will constantly measure the blood sugar level over a period of about 3 days. The problem is the sensors tend to wear out and get clogged off after 3 days, so you have to implant a new one. And it's hooked up to a little meter, and it constantly reads out the blood sugar level. And so this gives you literally a minute-to-minute idea of what's happening to your blood glucose level. And of course, this allows individuals to adjust their insulin in a much more rational way. Of course, these glucose monitoring devices are quite expensive, and ultimately, what we hope we'll be able to do, and in fact there are systems that are currently being tested, is to take that glucose sensor and hook it up to a little insulin pump, and the sensor will tell the pump how much insulin to give. And there already are now a number of companies that have developed these, we call them closed loop systems, artificial pancreases, that are being tested under the auspices of the Food and Drug Administration. We also have spent a lot of time and effort trying to harvest beta cells from individuals who may have passed away and then leave their pancreas for other individuals, and this is called islet transplantation. There's been an enormous interest in this area, and unfortunately on a long-term basis this hasn't lived up to the expectations that we had hoped for. There are a lot of people who are trying to genetically engineer beta cells to make cells. This is an exciting area, but we've got a long way to go, I think, before this genetic engineering is going to come to fruition. And there are a lot of innovative ways to try to block the immune response that are currently being tested. So there's, I think, a lot of interest in this area, lots of research being done, but ultimately, at least for the near future, we're still going to require insulin for our type 1 patients. Now for type 2 patients, we actually have a lot more choices. So remember I said type 2 diabetes, there are 2 problems. Number 1, your body doesn't respond to the insulin normally. And number 2, eventually your beta cells wear out, you don't secrete enough insulin. So we have 2 types of medicines in general. One type of medicine improves how your body responds to insulin. and the other makes your body, your beta cells, make more insulin. So the first class or the first approach involves what we call insulin sensitizers. So if you're resistant to insulin, let me see if I can improve the sensitivity. So we call them insulin sensitizers. Now, believe it or not, until 1995, we had only one class of drugs for the treatment of diabetes, called sulfonylureas. And I remember we used to fight, so which sulfonylurea is better than the other sulfonylurea. And you know what we now know? They're all exactly the same, okay? And we also know that these are archaic drugs, okay? And we don't use them anymore. They're dropping off tremendously, or they should be dropping off tremendously in my opinion, okay? So in 1995, we had the first new class of drugs introduced into the US market that was an insulin sensitizer, and this drug that was introduced was called metformin, or glucophage. Now, how many people in this room use glucophage? So a lot of you, because this is the #1 drug in the United States. So who do you think brought that drug to the United States? I actually heard he was here visiting you tonight. In this room maybe, okay? So glucophage is actually an old drug, and in 1995 it celebrated its 50th anniversary. It had been used everywhere in the world. But the FDA, the Food and Drug Administration, had a very negative feeling about this drug. And so it never really got approved in the US. And finally, a French company tried to bring it to the US, got me involved in the development. And in fact, it eventually did get approved. And it is now the #1 selling drug in the United States. And of course, it's gone generic now. And the other nice advantage of this drug is in the state of Texas, it's $4 a month. That's pretty good, okay? Now, subsequently, and this drug has caused, or this class of drugs has caused a lot of controversy. Around year 1999, we had another insulin sensitizing class of drugs, the thiazolidinediones. And there were two of them, rosiglitazone and pioglitazone. The brand names are Avandia and Actos. So, how many people in this room take either Avandia or Actos? See, not any of you in this room. So in my opinion, actually, this class of drugs, along with another class I'll tell you about, are the best drugs for treating people with type 2 diabetes, even better than metformin. Now, all drugs have some side effects, and of course you shouldn't run out and tell your doctor that you want to put on this drug, because there may be contraindications for you being on the drug. Rosiglitazone you probably heard about, because this is the one that caused a lot of trouble with the Food and Drug Administration, and that it looks like this drug increased the likelihood of you having a heart attack or stroke, and so it's been largely removed from the US marketplace. In fact, you have to fail every other drug in order to even get this drug prescribed. The other drug that's very similar to this, pioglitazone or Actos, sort of like a black cloud. When it's up there, it hangs over everything. And so people got a little bit nervous about using pioglitazone Actos, in large part because of the problems with rosiglitazone. But in my opinion, this is one of the best drugs for treating diabetes. But of course, unlike metformin, which is very inexpensive, this one's very expensive. It's like $210 a month. So all of the new drugs, which are the good drugs, are very, very expensive. So we have drugs that will improve how your body responds to insulin, and then we have drugs that will improve how much insulin your body makes. So there's one class of drugs, we call them the DPP-4 inhibitors, and in this class of drugs are things like, and I don't know that anyone is on any of these drugs, saxagliptin, vildagliptin, alogliptin, sitagliptin, they're all called gliptins. I don't know that anybody is on this class of drugs. Do any of those names sound familiar to you? Okay, Januvia, a lot of people are, yeah. So Januvia has actually become pretty popular. That's called sitagliptin, okay? And so this is one that's recently, in the last several years, and it's become very popular with primary care physicians. It's modestly effective, and it's really quite safe. Very, very, very few side effects. But it's also very expensive, between $275 or $300 a month. And then there are even more powerful drugs that are very similar to Januvia, but they require an injection, okay? One of them is called exenatide or Byetta. Anyone on this one? Liraglutide or Victoza, okay? So these two drugs actually, in addition to making your beta cells produce more insulin, they stop your beta cells from dying on a long-term basis, and they also turn off your appetite and promote weight loss. And I actually like this class of drugs very, very much, but also very expensive, okay? About $300 to $350 a month. So we actually now have medications that work really quite well. But the problem is they're very, very expensive. And most insurance plans want you to go with the older medications, which in my opinion don't work very well. The problem with the older medicines is by the time you find out they're not working, there have been a lot more of your beta cells than their insulin producing cells which have died. And so now the medicines that really will work, they won't let you use them until you fail on the older medicine. So this is, finance is of course a big problem. And this is a difficult problem to overcome because the development of these drugs now is so expensive. It's in the order of $700 to $800 million to get a drug to market. So obviously if a company spends a lot of money getting the drug to market, they need to recoup their losses. These companies are in business to make money. So we actually have very good medicines to treat our type 2 diabetic patients, but a lot of people cannot afford them. I have, of course, a great interest in type 2 diabetes, and I've been very much involved in the development of some of these drugs. There are lots of new avenues of research in terms of insulin sensitizers that we've been working on, new drugs that will work even better in terms of increasing insulin secretion. And we will have newer and better drugs approved as we go forward, but the newer the drug, of course, the more expensive it's going to be because the cost of everything is going up and up and up. So I would say the future is bright for both type 1 and type 2 diabetes. We already have very good drugs. We have better drugs that will be coming in the future, but cost is always going to be an issue, and we always end up balancing how effective are the drugs versus who's going to pay for them. Okay, so if you have a very good medical insurance plan, the co-pays can be reasonable. But even for some of these more expensive drugs, the co-pays can be really quite difficult. But in addition to controlling the glucose, if you're a diabetic, in my opinion, all diabetics should be on what we call a statin drug to lower your LDL cholesterol. I would say there's virtually no diabetic patient who should not be on one of these medications. Your blood pressure must be very, very well controlled, because if you're a diabetic and your blood pressure goes up, that actually causes much, much, much more damage much more quickly than in someone who is not diabetic. If there's not a contraindication, okay, in high-risk people with diabetes, we also recommend that they take at least a baby aspirin per day. But again, if you have ulcer disease, it's not recommended you take it. So although the things that I'm talking about are generally recommended, for each individual, you need to discuss with your doctor whether there are contraindications to taking these medications. So I'm going to stop at this point in time. You've been very quiet. Usually when I give a talk at the university, I have to deal with obnoxious people who are yelling and screaming and throwing things. You're a very sedate audience here, okay? So you should feel free to ask whatever questions, either personal or general, and I'll try to answer them. Yes, sir.
I see on TV occasionally these advertisements for different, what do you call them, evaluations, what do you call them?
Oh, the A1C test?
No. Where you go to San Antonio and spend days in the hospital and get on these research exams. Which ones can you trust and which ones?
So you need to call me and ask me. So you'll see advertised on the TV and radio all the time. If you have diabetes and your A1C, which we should talk about in a second. If your A1C is above a certain level, meaning you're not adequately controlled, you might be a candidate for a new drug that's being developed. So I would say in general, all of these new drugs have merit, and you need to understand that the Food and Drug Administration wouldn't allow any of these drugs to start to be tested unless they felt it was safe. Now, the reason why we do these studies, which involve really hundreds of thousands of people, is to find out how effective the medications are and how safe they are. And I would say that I don't know any endocrinologists or doctors who would ever use a drug that they felt was unsafe. So all drugs have side effects. There's no perfect drug. But you need to understand that diabetes has some serious side effects, like going blind, having kidney failure, okay? So you always have to, weigh the risks versus the benefits. But I would say that if you hear something that's advertised, all of these drugs are under a program that's being supervised by the Food and Drug Administration. So I think they're generally safe. A lot of benefits that you don't have to pay for the drugs. Virtually every drug that we've worked on has been approved by the Food and Drug Administration. So patients have been able to get the drugs free for many years in advance. Generally speaking, when you're in these research studies, the doctors are looking at your blood pressure, your lipids, and so if they find anything that's abnormal, they're going to either treat it or refer you back to your doctor to make sure they're treated. So I think in general, it's very good and very important for people with diabetes to participate in these research projects. I don't think any of us are trying to make guinea pigs out of anybody, and I certainly would not participate in any study unless I felt the medication was safe and had promise for the future. Yes, ma'am.
Would you consider a normal range for blood sugar?
Yeah.
Readings?
So there are two things that we do. Number one is you can prick your finger and you can look at the blood glucose levels. And then we have another test that's called the hemoglobin A1C. Or you may hear it as the A1C, or at times you'll be driving on the road and you'll listening to music, whatever, and there'll be an advertisement. Do you know what your A1C is? And in fact, you should know what your A1C is, just like you should know what your blood lipid levels and your blood pressure levels are. Now, having said that, I can tell you what's normal, but not every diabetic patient needs to get to normal. So a normal A1C, it's also called the hemoglobin A1C or glycosylated hemoglobin A1C, and a sugar-coated A1C, and I'll tell you a funny story about this in a second. But the normal value is 5.5 or less, okay? And then if your value is above 6.5, that's the level at which we make the diagnosis of diabetes. And there's kind of a gray zone in there we call prediabetes. And the ADA definition of prediabetes is your A1C is 5.8 to 6.4, okay? So if it's 6.5, you have diabetes. It's less than 5.8, it's normal, okay? Now, what your level of A1C should be really depends upon how long you had your diabetes, other complications that are present. So if you're 30 years of age, you've just been diagnosed with diabetes and you're otherwise healthy, in my opinion, your A1C should be perfectly normal. It should be 5.5. And that's basically what the American Diabetes Association says and what all the diabetes associations agree upon. On the other hand, and we can get you there with the medications, but the medications all have some side effects, okay? Now, let's say you're, 75 years of age, you've had 2 heart attacks and a stroke, okay? Well, I don't want to be overly aggressive there, so maybe an A1C value, even though the ADA sort of general cut point is 7, maybe you're better off to be between 7, 7.5. Because if I try to get you too low and you get a low blood sugar, then maybe I can cause you to have another heart attack. So we know what's normal, but not everybody should be at normal. It depends upon the other medical conditions. And that's why you need to discuss with your doctor what is the optimum value for you. Now, in terms of blood sugar levels, when you get up in the morning, your fasting blood glucose is 80. But you know, if you try to get everybody down to 80, some people are going to go down to 50. They're going to have a low blood sugar reaction. So we say in general that the fasting range should be 80 to 120. And then after you eat a meal, it shouldn't go really much above 150 to 160, okay? But again, for people who have other complications, maybe you want to loosen up on that range a little bit. So you really should discuss this with your doctor, what is optimal for you. And it's always more difficult to get into the range using insulin than it is with some of the oral agents. But at some point in time, if your beta cells die off, you're going to have to go on to insulin. And then that becomes much more difficult to regulate people, because now you have to check your glucose much more fastidiously. And then you have to be adjusting your dose of insulin with each meal based on where your starting glucose is. And part of the story that we didn't talk about, every person should go through the ADA education course, which is a minimum of 10 hours, to teach you about the kind of complications that diabetics have, teach you a little bit about your disease, about the medicines, how to adjust the medicines. And then I would say at the Texas Diabetes Institute, we see about 10,000 unduplicated patients per year. Almost all of our patients come back for additional training, either one-on-one or group training. It's the more you know about your diabetes, the more you're going to be able to adjust. You may have your doctor appointment every 6 months, every year, but in between, you need to make the adjustments yourself. So we try to educate our patients as best as possible. So not only can you make the adjustments, but if you see there's something wrong that you don't understand, you know to call us. And then we can work with you to get things straightened out. So the more independent you are, the more you know about your diabetes, the better off you are. Yes, ma'am.
Is there, about 2 weeks ago on Good Morning America, they had a controversy about whether or not to take the baby aspirin.
Yeah.
But you just said we recommend to take baby aspirin.
Yeah. So this is controversial, okay? Now, I would say if you're a diabetic, okay, and you have high risk characteristics, so let's take the example, you're a diabetic and you had a stroke or you had a heart attack, okay? For sure you should be on an aspirin, okay? Let's say you're a non-diabetic and you're otherwise healthy. Then I would say probably you're not going to benefit from being on the aspirin. So the more risk factors you have, the more likely you are to benefit from being on the aspirin. But if you're on the aspirin, you can also have an ulcer and bleed from it. And if you have a stroke, you can bleed into the stroke and can make things worse. So again, this is another thing that you should discuss with your doctor. So if there are predisposing conditions, particularly ulcer disease, you probably shouldn't be on a baby aspirin. If you don't have a predisposition to bleeding, and if you have, say, lipid abnormalities, blood pressure abnormalities, and you have diabetes, you probably should be on the aspirin. So again, it's not an all or none thing. In my opinions, for statins, every diabetic should be on a statin to lower your LDL cholesterol. To me, there are no exceptions to that rule, and I would say most people in the endocrine field feel that way. In terms of blood pressure, I think we all believe that your blood pressure should be as close to normal as possible. But as you get older, your blood vessels get stiffer, and so there's the doctor will tell you your normal blood pressure is 120/80. So the top one is the systolic blood pressure, and the bottom one is the diastolic. But as you get older, your top blood pressure tends to go up. So it may be, say, 135 or 140/80. Now I'd like to lower the top one, 140 down to 120, but that means I'm also going to lower the bottom one. And I may end up lowering the bottom one too much. So again, you have to, each person is going to differ as to how you're going to lower the blood pressure to what level. So in general, you should be as close to normal as possible without doing any harm. Yes, ma'am.
In the media, you're kind of starting to see people talk about reversing diabetes, type 2 diabetes. What do you think about that?
What does reversing mean?
Right.
If you mean a cure, you know, I think that there is a way to get a cure. You can go back in life and choose over again and get 2 new parents who don't give you any genes for diabetes. I think that's kind of tough to do. So I think that with the medications that we have, if you start early enough and you use the newer medications, I think that you can get your diabetes under control. And if your blood sugar level is within the normal range, you for sure are not going to develop the eye, kidney, and nerve complications, okay? If you wait too long, at some point, you don't have enough beta cells, so no matter what of the medicines you use, you're eventually going to have to go on to insulin. And maybe part of what you're talking about has to do with this bariatric surgery or the surgical procedures.
Well, there is talk also outside of the bariatric surgery about plant-based diets and those types of diets, real strict diets helping you with insulin sensitivity.
So, as I said initially, the biggest problem that we have that's driving the diabetes epidemic is being overweight. And so there are all kinds of diets that are out there. And I think it's very, very clear that there's nothing magical about a diet, okay? They've all been debunked. The only thing that's important is how many calories that are in the diet. A calorie is a calorie is a calorie is a calorie. If you eat too many calories, you're going to gain weight, okay? If you eat fewer calories than you burn up, you will lose weight. Now, I have strange eating habits, okay? So I don't eat breakfast, I don't eat lunch, I only eat at night. I would say I wouldn't recommend that for most of my patients. My wife or my ex-wife, she used to eat like 6 or 7 times a day, small amounts of food. She was a model, she looked great. I can tell you, if I told my diabetic patients you should eat 6 or 7 small meals, they'd all have a BMI greater than 40, okay? So my sort of approach to this is whatever diet works best for you is the diet you should be on. The one exception you have to be careful about is if you may look relatively normal in terms of weight, but if you're on a very high saturated fat diet with a lot of cholesterol, that would not be good, okay? So I think if you have a normal distribution of calories, whatever you're doing to keep your weight normal is okay. And then people always ask me, well, what should my weight be? So I have a very simple answer to this. You get up in the morning, okay, you look in the mirror, you look fat, God damn it, you're fat, okay? It's very simple, okay? And for women, they know when their dress size goes, from an 8 to 10 to 12, and guys, when they have to go and get new belts, okay? There are lots of clues that will tell you, okay? And the unfortunate thing is we get older, we all tend to gain a little bit of weight around the midsection, including myself, and it's not so easy to, I think if we all look back to our high school days, there are probably not too many people in this room, maybe John or Lynn, they can say they weigh the same now as in high school. Now, I actually weigh about 10 pounds less, but I looked a lot different when I was playing football and lifting weights than now. So, you can be bigger and have muscle mass, that's okay. You can be smaller and have a lot more fat and still weigh the same amount. Other questions? Yes, ma'am.
Back to the medications, for diabetes.
Yeah.
The medication, Glipizide. What is, we know what that does.
Glipizide or
Glipizide.
Yeah.
Right.
That's one of the older drugs. It's one of the sulfonylurea drugs, okay? Now, I make this statement because I say it to physicians and I say it to patients. I haven't used the sulfonylurea since 1998. I don't recommend that you use them. I don't believe they should be in guidelines for treatment of diabetes. I do with my patients exactly what I would do with myself and what I say. It's one of the older drugs. It's in that class of drugs that we had before 1995. These drugs work initially, but after a year to a year and a half, they stop working. The doctor gets the false impression that the blood sugar level's coming down, and it does come down, but your beta cells are still dying. So there's some drugs that will lower your blood sugar and save your beta cells. There's some that will lower your blood sugar, but your beta cells still die. And in my opinion, sulfonylureas are one of those classes of drugs that will lower the blood sugar level, and the doctor feels comfortable because he's looking at the blood glucose. But the health of the beta cell is not being maintained. And that's an important distinction. And I can tell you, many physicians don't understand this difference either. Okay, so I actually don't like using sulfonylurea drugs, and there is an organization called the American Association of Clinical Endocrinologists, and they specifically tell you not to use a sulfonylurea drug as first-line therapy.
But if you use it, along with the metformin.
Yeah, so
It's like,
the problem is the metformin is a very good insulin sensitizing drug. It takes care of part of the problem. It doesn't save your beta cells. And the sulfonylurea doctors think it's working on the beta cell. And it is in some ways, but in terms of saving the health of the beta cells, it's not. So I actually like metformin. It's part of first-line therapy in all of my patients, but I don't like the sulfonylurea. I would prefer you to be on one of the other combination, like Januvia, the DPP-4 inhibitor, or GLP-1 analog, which is an injectable, or the pioglitazone, because these drugs actually have a long, durable effect on your beta cells. Yeah.
Ralph, elaborate a little bit on those GLP-1, the ones that preserve the beta cells and help patients to lose a lot of weight.
Yeah, so the first one that came was exenatide. It's also called Byetta. And this is a drug that you take twice a day, and you take it about 30 minutes before the meal. It's in this class of drugs that we call GLP-1 analogs. That's not very important, that you all know this, but it has a specific effect, not only to make your beta cells make more insulin, but it saves your beta cells from dying on a long-term basis. And we have very good scientific evidence that this is true. Number two, it works in the areas in the brain that regulate your appetite, and it turns your appetite off. And over the course of a year, the average weight loss is in the order of about 10 to 12 pounds, whereas most diabetics tend to gain weight. It also has a beneficial effect to lower your blood pressure, and it also has very beneficial effect to lower the blood lipid levels. So I like this class of drugs. Next came, about a year and a half ago, a drug called liraglutide or Victoza. And Victoza has the advantage over Byetta, the one that we were just talking about, and that you can give it once a day, anytime during the day. So for my patients, I actually then started recommending Victoza, not because it's any better than exenatide, but it's easier for the patient. If you have to take something twice a day and you have to time it with the meals, as opposed to once a day, it's just easier. And then about 2 or 3 months ago, we had a new one. It's called Bidurion in this class of drugs, and it's given once a week. And there are drugs that are in development that actually, in this class, which will be given once a month, and actually a little implantable osmotic mini pump that you can put under the skin that lasts for a year. So I actually use these drugs as first-line therapy with metformin right from the beginning. And I also use a third drug, pioglitazone, and I use them all together right from the beginning because I, particularly in newly diagnosed patients with type 2 diabetes, I want to preserve your beta cells. Now, what we know is that this class of drugs, we have 3 years of really good follow-up of patients. While you are taking these drugs, you maintain normal beta cell function, and you make a normal amount of insulin. If you stop the drug for 24 hours, your beta cells go back to their old 6 state. So a lot of doctors say, well, yeah, well, so what's the sense of that? Well, the sense is, look, if you stay on the drug for your whole life, okay, you'll have a normal blood sugar. Your blood sugar is not going to be high. If your blood sugar is not going to be high, you won't develop eye and kidney and nerve damage, okay? And then, of course, what do the insurance companies say? They say, show me a 15-year study where you protected the eyes and the kidneys. Well, the fact is I can't do that because no one's going to do a 15-year study because the drug will be off patent. So the insurance companies and the third-party pays always fall back on show me the evidence that over 10 or 15 years I protect you from having a heart attack, a stroke, going blind, developing kidney failure. Well, I can't do that. So this is my comment to them. You have to be a damn idiot, okay, to say that to me. Because if your blood sugar is normal, you show me a normal person anywhere in the world with a normal glucose who develops eye, kidney, and nerve damage. Show me one person, okay? And of course, if you have a normal glucose, you're not going to develop these complications. Now, you may still have a heart attack because your lipids are high or your blood sugar is high, but you're not going to go blind, you're not going to develop kidney failure, you're not going to develop this painful neuropathy as long as your blood sugar. So I think people become a little bit irrational in demanding these long-term studies. Now, of course, they have to pay, and these drugs are expensive, I understand that, okay? But I can tell you that I wouldn't do anything for my patients that I wouldn't do for myself, and I would take these drugs, okay? Quality of life. How many people in this room have been blind? Other than me. So I was blind for about a week, but I can see you all quite fine now. So if you've had, and I also took care of dialysis patients. So I know what dialysis patients feel. It's miserable if you have to come 3 days a week to the dialysis unit. The day you're on dialysis, you feel miserable. It takes you 24 hours to recover from the dialysis. And if you're blind and you're sitting there thinking, well, damn, how am I going to read? How am I going to continue my job? Okay? And, you know, if you have to walk across the street and you have to listen to the clicker to go, believe me, I tried to do that and I chickened out. So there's no amount of dollars that can repair the quality of life if you develop kidney failure or blindness. So personally, I would pay to make sure that my blood glucose stays normal. But the cost is always an issue. And you always have to balance what we know the drugs will do versus the cost of drugs. And this is not always an easy choice because many patients simply cannot afford the newer drugs. And it's an easy fallback for third-party pays to show me that these expensive drugs are going to prevent you from going blind. So what we know is for 3 years, I can bring your blood sugar level down, I can normalize your beta cell function. Well, what happens after 3 years? Well, we don't have studies that go on after 3 years. So with the pioglitazone drug, we have studies for 5 years, okay? So what happens after 5 years? I don't know. So what about sulfonylureas? I know after 1.5 years you're failing, okay? So this is what I know. So, and what I've told you could be verified by any doctor you talk to. So you are all a lay audience. So let's say you, forget about the cost. So I tell you, look, here's a medicine to lower your blood glucose, but after 1.5 years, I know it's going to stop, it's going to fail, and your blood sugar is going to go up. Or I have another drug, I can give it to you for 5 years, and your blood sugar will come down and stay down, but I don't know what will happen after 5 years. And I have another drug that will take your blood sugar down and will stay down for 3 years, I don't know what's going to happen after 3 years. Which one are you going to pick? You're going to pick the one that's going to work for 5 years or 3 years, okay? And you know, if your blood sugar goes up after 5 years, then we'll add another one. And maybe you'll get 3 or 4 more years where it stays down. The fact is, we don't have the kind of long-term studies that we should have, and no one's going to do them in the pharmaceutical industry because they're so expensive and they run up the cost, and they want to get the drug on market as quickly as possible. So I think the National Institutes of Health really needs to get behind this. It needs to be pushed by the American Diabetes Association so that we really get some long-term data. You know, if people always say, well, yeah, but you still won't know for 5 or 10 years. But you know, if you keep saying that, now you're 10 years later, you still don't know the answer. And then you're 10 years later, you don't still know the answer. So at some point, you just have to say, look, let's just do the study, let's see what's going to happen. And you know, we look at all of the drugs and we test them one against each other. And unfortunately, that's never been done. Yes, sir.
What about Janumet?
Yeah.
Janumet?
Yeah, it's a good drug. It's like the injectable that we were just talking about, but it's not as strong, in my opinion, as the injectable. It does what the injectable does, but because it's not as strong, it doesn't make you lose weight. It has a modest effect to help your beta cells, but not as strong as the GLP-1 analogs. Primary care physicians and patients tend to like the Januvia, the Janumet, which is a combination of Januvia and metformin, because it's a pill, it's easy for the patients to take. So they very commonly recommend it. For all of my patients, I put them all in a GLP-1 analog, which is an injectable. And the difference is, of course, I have more time to work with the patients, and also I think the patients believe me. If I tell them this is the drug that I would use, this is the best drug, they will do it even though it's an injectable. So the exenatide, every drug that I've ever given to a patient, I personally have taken myself. So the exenatide, I've taken, you take it twice a day. The Victoza, I take it once a day. First of all, the needle is so small and so thin you can hardly see it. And I inject myself either with the exenatide twice a day or with the Victoza once a day. I can honestly tell you I never once felt the needle. It's so small. Now the one that you take once a week, you definitely will feel a pinprick when you do it with once a week. And I explain to my patients, look, would you rather take it once a week? You know, like, you know, if you're Catholic Sunday morning, if you go to church, if you're Jewish on Friday night when you go to the synagogue. If you don't have a religion, you better get one so you can remember to take it once a week, you know? So, and you get that one prick, but then you take it once a week, or would you rather take, you know, every day with the little thin needle? And different people prefer different, you know, differences. So it's kind of a matter of style, and primary care docs oftentimes don't have the time to sit with you and explain how to use the injectable, and it's much easier to give you the tablet. But they're good drugs. I mean, I'm not saying they're bad drugs.
Actually, I'll start off with Janumet, but I don't remember what the name of it is now. KOL, it's a long name. I don't remember what the name of it is. But it was expensive. It was,
Oh yeah, the new ones are all expensive.
$200 something.
Yeah. Yeah. Yes, sir.
I'm type 2 diabetic, and I'm on insulin now. What treatment would you say on insulin? And what could you do if you were type 2 and I guess you got to the point of using insulin?
Yeah.
What did you do then?
Well, without knowing you and what your A1C and your glucose and what all any other problems you have, you know, it's impossible for me to tell you what to do. But generally speaking, we try to stay with the oral agents, okay? And we don't go to insulin therapy unless you truly fail on the oral agents. My personal belief is that if you fail on the oral agents, I would always put you on one of these GLP-1 analogs before I put you on insulin. So by the GLP-1 analogs, it's that Victoza, the exenatide we were talking about. And why would I recommend that? These drugs do not cause hypoglycemia, a low blood sugar, whereas insulin can cause a low blood sugar. These drugs make you lose weight, whereas insulin tends to make you gain weight. You have to do a lot more intensive monitoring if you're on insulin because of the issues of hypoglycemia than you have to do with these drugs. These drugs basically is maybe one step in titration. You get on the maximum dose. Insulin, you're always having to adjust the dose of insulin. So I would never go to insulin therapy unless I tried you on the GLP-1 analog. And insulin therapy is very expensive, particularly when you count in the strips for, you know, like the strips generally are about $1 per strip. And if you're checking your glucose 3, 4, 5 times a day, that amounts to $3,000, $4,000 a year. So it can be very expensive. So I don't know your situation exactly, but what we tried to do is if you have to go to insulin, we try to control you on 1 shot of a long-acting insulin. There are 2 long-acting insulins, glargine insulin and Levemir, or Dedamir, they're both very good. And then if 1 shot of the long-acting insulin doesn't work, then we'll have to add a short-acting insulin with each of the meals. So I don't know where you stand, and so it's impossible to give you advice as to what you should do or not do. And we also tend to keep an insulin sensitizer on board, because even though I'm replacing the insulin, your tissues are still very resistant to the insulin. So we tend to keep metformin or the pioglitazone on board, which allows us to use less insulin and get better control of your blood sugar. So it's obviously complicated, and you know, your doctor would have to work with you to make sure you're on the right dose of oral agents and insulin. Yes, sir.
Based on what you said a while ago, my doctor's got me on Januvia and Glimparide.
Yeah.
And you're telling me this Glimparide, you don't recommend it. Is that correct?
I don't use it.
Okay. Well, does the Januvia do this?
So
If you took just it and metformin.
yeah. So the reason why I don't get too shook up, because you're on Januvia and that drug has an effect to preserve your beta cells, okay? What I'd get really shook up if you were just on the sulfonylurea alone, or the sulfonylurea and the metformin, because the metformin's a very good drug, but it doesn't save your beta cells. So the metformin improves how your body responds to the insulin, that's very good. The Januvia helps your beta cells, so that's okay. So if you're on the other drug, I don't care, okay? What would bother me if you were just on the other drug and not taking the other?
Well, see, I've been debating why am I taking both of these, and I have thought about not taking the Glimparide and taking just the Januvia.
The glimepiride may still be doing something, so if you stop it, your blood sugar can go out of control. So don't leave and say Dr. D said that just stop the drug cold turkey, okay? You need to work with your doctor, and you know, it's likely that if he's... See, the problem with this class of drugs is that although it will lower your blood sugar, it won't keep your beta cells healthy, okay? So you have this false impression because your blood sugar comes down, it's okay. But it's not okay, because your beta cells are dying and eventually the drug's going to fail. But you are on other medication, the Januvia, that's going to help save your beta cells.
Well, I'm on metformin, Glimparide, and Januvia.
Yeah, so that's okay. But I don't think the clomipramide, or whichever one you're on, is doing a whole lot of good. But I wouldn't change it without talking to your doctor, and if it's going to be, if you're going to change it, you're going to have something else probably. Yeah.
I've been on metformin for about 10 years, so do you think my beta cells are dead?
I think if the only drug you're on is metformin and nothing else, the natural history is that your beta cells, which are the insulin-producing cells, tend to decline.
Can I bring it back to life?
I wish I could ask my father that question up there. Well, I mean, see, I don't know what your A1C is. I don't know really anything.
About 6.7.
So that's actually pretty good. But I probably would add something else to your regimen.
How do you spell that, Victoza?
Victoza, V-I-C-T-O-Z-A.
One more time.
V-I-C-T-O-Z-A. And as I said, it's also very good to promote weight loss, which will help your diabetes as well.
Insinuating?
No. Thank you.
I look at it too.
Yes, sir.
I get my health care with the VA in Victoria,
Yeah?
and they've told me that they're very limited to what they can get. I've
Yeah.
asked them for Byetta and Victoza, and they just took me off metformin like 3 weeks ago, and my blood sugar shot up
Yeah.
over 200 fasting in the morning.
I can't tell you how many fights I've had with the VA. So I'm part of the VA system, and they took rosiglitazone out of the VA about a year or so with this business of cardiovascular, which is fine. but then they elected not to put pioglitazone. So I wrote them, I can't tell you how many letters to VA headquarters, and you know, they don't respond. I keep writing. So finally, someone wrote back and said, oh yeah, well, we have all these emails and stuff, but you never send us your conflict of interest statement. So I wrote and I said, well, since I work for the VA and since I knew you were going to ask this, I sent it with the very first email. So then they wrote back and said, oh, you're a whore, you're on the advisory board for every pharmaceutical company in the United States, including Takeda, your input is totally worthless. That's basically what they wrote back to me. So I have a big problem with the VA. We're willing to send people overseas, okay? They get, some people die, some people don't come back, some people back with injuries, they develop diabetes, and they have the worst medicines for the treatment of diabetes in the world. They should have the best medicines, in my opinion. You cannot get any of those GLP-1 analogs, okay? Despite what they say, they block every attempt. You've got to write 1,000 letters and they kind of wear you down, and they don't have pioglitazone in the formulary. So they have the older drugs, which in my opinion work the least, and I think that veterans should get the best drugs, not the worst ones. They're very cost conscientious. Those sulfonylurea drugs are $4 a month, metformin is $4 a month. And you know, I don't care what they say, that's the only reason why they're in the formulary.
I have time for one question, Dr. DeFronzo.
Yeah.
So in other words, I take the Levomil Flex pen.
Yeah, it's a good one, yeah. Yeah. Well, no, the Levomir insulin and the Glargine insulin are both very, very good. And if you can be controlled on just the one shot of insulin, that's great. Most people need one of the insulin sensitizers. You take the Januvia with it. Yeah. Yeah. So again, the key thing is the outcome. You know, is your A1C okay? Is your yeah. Woo! I like that. You come and be my patient. You know, I say this all the time. If the patient wants to, you know, defeat the doctor, the patient will win 100% of the times. You know, so you have to have people who. That's why education is so important, because it's difficult. You sit here today, particularly young people, they don't understand 20 or 30 years from now what the complications are going to be. They think they're invincible. Like, I still think I'm invincible, okay? But someday I know I'm going to die. But I'm smart enough to not hasten this along, you know, by doing things that are going to hurt my health. So I try to take care of it best I can. But that means if you have diabetes, you have to work at this. So you can't wait till you have all the complications, then all of a sudden get religion and think the complications are going to go away. They're not. And it's difficult to envision 20 years into the future what the complications are going to be. Because if you could, you'd probably behave yourself earlier. Okay, I think we're going to end because I'm giving another talk to physicians over at the country club. So thanks for all coming, I appreciate it.